An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To understand the basics, let's start with an example of how we can look at the heart with only one pair of electrodes, a positive one and a negative one. Remember that at rest, cells are negatively charged relative to the slightly positive outside environment. And when they depolarize, the cells become positively charged, leaving a slightly negative charge in the outside environment. So let's say that when this set of cells is at rest, they're red. And then they turn green as the wave of depolarization moves through them. Now, if we freeze this wave of depolarization as it's moving through the cells, half of the cells are positive or depolarized, and half are negative or resting. And so there's a difference of charge across this set of cells. You can think of the charge difference as being a dipole, because there are two electric poles. And we can draw this dipole out as an arrow or vector pointing towards the positive charge. And remember, the electrodes detect charge on the outside of the cell. So this points toward where the positive charge is outside the cell. Now, if there's a dipole vector pointing toward the positive electrode, then the ECG tracing shows it as a positive deflection. The bigger the dipole, the bigger the deflection. If we unpause this, then everything becomes depolarized. And since there's no difference in charge now, there's no dipole, and so there's no deflection. Moments later, a wave of repolarization goes through. Pausing halfway through again, now the vector dipole goes in the opposite direction and faces the negative electrode, which means there'll be a negative deflection on the ECG tracing. Again, the bigger the dipole, the bigger the negative deflection. Now, even though it'd be nice if the depolarization wave lined up perfectly with the electrodes, usually that's not the case. So what we end up looking at is the vector component that's parallel to the electrode. For example, let's say the depolarization happened this way, at an angle. Then we'd break the vector into two parts, one going parallel with the electrodes and one going perpendicular. The one we care about is the one that's going toward the positive electrode, which causes the deflection. Though since this arrow is shorter, it's going to cause a slightly smaller deflection than previously. In other words, the size of the deflection on the ECG tracing always corresponds to the magnitude or size of the dipole in the direction of the electrode. The perpendicular component isn't pointing at the electrode, so it doesn't cause any deflection. In fact, if there's a depolarization wave that goes straight up, which is perpendicular to the positive and negative electrodes, then there'd be no deflection at all. In a standard ECG, there are 10 electrodes. 4 limb electrodes, one on the left arm, left leg, and right leg, and 6 precordial electrodes, V1 through V6, that wrap around the chest. And the right leg electrode is usually used as a neutral lead. Now, the heart's a 3-dimensional organ, right? So V1 through V6 line up in the transverse or horizontal plane of the heart. And each electrode is set up to detect any wave of positive charge coming toward them, which based on what we know already means that they're positive. These are collectively called the chest leads. Meanwhile, in the coronal plane, the non-neutral leads are called augmented vector right, or AVR, on the right arm, and augmented vector left, or AVL, on the left arm, both of which are represented as vectors that are 30 degrees up from the horizontal line. Finally, there's the augmented vector foot, or AVF, on the left foot, which anatomically isn't straight down, but it's close enough that it ends up representing the vector facing straight down on the diagram. Just like the precordial electrodes, AVR, AVL, and AVF each detect any positive deflection coming toward them. Now, in addition to these 3 limb leads, there are also bipolar limb leads called lead 1, 2, and 3, which are recorded using 2 electrodes instead of just 1. Lead 1 uses the right arm as the negative pole and the left arm as the positive pole, forming a vector that goes to the right. Lead 2 uses the right arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 60 degree mark. And lead 3 uses the left arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 120 degree mark. So in total, you've got 6 leads from the limb leads and 6 from the chest leads, leading to a grand total of 12, which gives you your 12 lead ECG. Now, the point of having all these leads is to get different views of the heart, making it easier to see exactly how that wave of depolarization moves through the heart. As an example, consider how the 6 chest leads, V1 through V6, register the depolarization waveform called the QRS complex. The exact same depolarization wave might appear mostly negative in V1 and V2. It might be isoelectric in V3, and mostly positive in V4, V5, and V6, all because of the exact direction and magnitude of the vectors at different points in time. Similarly, each of the limb leads produces its own viewpoint of the depolarization wave as well. Now, all the limb leads and chest leads can be grouped based on the regions of the heart that they're nearest. Problems in specific leads or groups of leads suggest that there might be a specific region of the heart that might be affected by a disease. Leads 2, 3, and AVF are inferior leads because they're near the inferior wall of the heart, which receives blood from the right coronary artery. Leads 1 and AVL, along with 2 of the chest leads, V5 and V6, are all considered lateral leads because they're near the lateral wall of the heart, which receives blood from the left circumflex artery. Finally, V1 and V2 are considered septal leads because they're nearest to the interventricular septum, and V3 and V4 are anterior leads because they're nearest the anterior wall of the heart. Both of the septal and anterior regions are served by the left anterior descending artery. Alright, as a quick recap. In a standard ECG, there are 10 electrodes, 4 limb electrodes and 6 precordial electrodes that wrap around the chest. These electrodes are used to make 12 leads, each of which illustrates the movement of positive charge on the outside of heart cells. The ECG tracing shows a depolarization wave moving towards an electrode as a positive deflection, and one moving away as a negative deflection, each of which is proportional to the size of the dipole. The point of being able to get different views of the heart is that it makes it easier to see how the wave of depolarization moves, which provides valuable information about the heart's structure and function. Thanks for watching this video on the basics of ECG. But actually, this is only episode 1 of an 8-part series on ECG. To get access to those 7 additional videos, head over to osmosis.org, create an account, and start your free trial. In addition to extra videos, you can also find tons of other awesome content and tools to excel in your classes and on exams. An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, it's really helpful to first understand what a normal sinus rhythm looks like. To do that, let's look at a single heartbeat on an ECG, from the viewpoint of lead 2. In a healthy heart, everything starts at the sinoatrial node, or SA node, which is a little patch of tissue in the wall of the right atrium full of pacemaker cells. When one of these pacemaker cells depolarizes, a wave of positive charge spreads outward, and overall it moves from the SA node towards the apex of the heart. So it aligns pretty nicely with the lead 2 vector. Now, the heart muscle cells are often described as having a functional syncytium, because even though each one cell has its own membrane, The cells also have tiny connections or openings between them. That means that during a depolarization wave, ions can flow right from one cell to the next. Now, it's also important to mention that the depolarization wave moves at two different speeds through the heart. In the pacemaker cells, which are special types of heart cells laid out like highways through the heart, it moves super fast. But it moves more slowly through the rest of the myocytes, which do the contracting. If the pacemaker cells are acting more like highways, then these types of cells are like cars moving through congested small streets. Now, the ECG measures out changes in time on the x-axis, where one small box is 0.04 seconds, and voltage on the y-axis, with each small box being 0.1 millivolts, sometimes called 1 millimeter. And 0 is called the isoelectric line. And then so the tracing shows positive or negative deflections away from this line. So a depolarization wave starts in the SA node, then goes through the atrial internodal tracts, also called Bachmann's bundle, over to the left atrium so that both atria basically depolarize together. The overall direction of that depolarization wave is in the same direction as the lead-2 vector, so there's a positive deflection on ECG called the P wave. Meanwhile, the signal also gets carried from the SA node to the AV node, where it gets delayed just a bit. And this allows the atria to fully contract and fill the ventricles with blood. During this delay, there's no depolarization wave moving towards or away from lead 2. So this shows up as a flat line, and the interval from the beginning of the P wave through this flat portion is called the PR interval. From there, the signal goes through the pacemaker cells that make up the bundle of His, and then into the left bundle branch and the right bundle branch. In addition to moving through the fast pacemaker cells, the signal also goes through the slow myocytes in the interventricular septum, in a direction that's slightly away from the lead-2 vector, since there's a ton of tissue here, and this creates a tiny negative deflection on the ECG, which is called the Q wave. From there, the depolarization wave flows down into the Purkinje fibers. Since the largest vectors are the ones in the left ventricle, which is roughly in the direction of lead 2, this creates a large positive deflection on the ECG, which is called the R wave. The apex of the heart depolarizes first, but then the wave moves back up to depolarize the top of the ventricles, which is in a direction away from lead 2, causing a slight negative deflection on the ECG, which is called the S wave. Together, ventricular depolarization creates what's known as the QRS complex. After tissue depolarizes, there's a brief period of time where there's no change in electrical activity, so the ECG goes back to the isoelectric line. The exact point at which it hits that line is called the J point, and for a brief time there's no net change in electrical activity, and this is the ST segment. After that, the ventricles have to repolarize, or become negative again, to reset itself in preparation for another wave of depolarization. Now, repolarization moves in an overall direction upward, opposite the direction of lead 2. So you might think that it should be a negative deflection, right? But really it's still a positive deflection, since this time it's a wave of negative charge. So essentially now when it's moving opposite to lead 2, it's a positive deflection on ECG. And this final wave is called the T wave. The T wave is more spread out over time than the QRS complex because repolarization is a slower process that takes place at slightly different times for each cardiomyocyte instead of happening all at once like depolarization. It's also worth mentioning that atrial repolarization doesn't usually show up at all on an ECG because the small vectors created by it get lost in much larger vectors that get created by the QRS complex. Alright, as a quick recap. On an ECG, there's a P wave, which corresponds to the atrial depolarization wave. Then an isoelectric line where the depolarization wave goes through the AV node. After that, there's a QRS complex, which represents ventricular depolarization, followed by another brief isoelectric pause, which is the ST segment. Finally, there's a T wave, which represents ventricular repolarization. An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down the septum. To read an ECG, there are a few key elements to keep in mind. And one of those things is looking at the intervals. In a typical waveform, there's a P wave, a QRS complex, and a T wave. In addition to that, though, there are certain intervals like the PR interval, the QRS complex itself, and the QT interval. The PR interval spans from the beginning of the P wave to the beginning of the QRS complex, and it represents the time from the beginning of atrial depolarization to the beginning of ventricular depolarization. It's normally about 0.12 to 0.20 seconds, which is 3 to 5 little boxes, since each box is 0.04 seconds. So the PR interval shown is about 4 boxes, or 0.16 seconds. Any deviation in the normal depolarization pathway from the SA node to the ventricles can change the PR interval. For example, if the atria are depolarized by an ectopic atrial focus, for example, an irritable atrial cell outside the SA node. If this ectopic focus is farther away from the AV node, it'll result in a longer PR interval, because the signal has to travel a greater distance. Alternatively, if it was really close to the AV node, the PR interval might be super short. Another example is first-degree heart block, where the electrical signal travels more slowly through the AV node than it normally does, and this causes the PR interval to lengthen beyond 0.2 seconds. Now, the QRS complex represents depolarization of the ventricles, and it's normally less than 100 milliseconds, or 2.5 little boxes. Just like the PR interval, the duration of the QRS complex can change depending on the path from the AV node to the ventricles. For example, if an ectopic ventricular focus like an irritable ventricular cell fires off, the resulting depolarization wave will move slowly from muscle cell to muscle cell, instead of traveling quickly through the electrical conduction system. Therefore, it ends up taking a longer time to depolarize the ventricles and the QRS complex gets wider. It's often considered intermediate if it's 100 to 120 milliseconds long, and prolonged if it's over 120 milliseconds, or 3 little boxes. Finally, the QT interval spans from the beginning of the QRS complex to the end of the T wave, and it represents ventricular systole, meaning the entire span from depolarization through repolarization. Normally, the QT interval should be less than half a cardiac cycle. In fact, for a heart rate of 60 beats per minute, the QT interval is generally considered to be abnormally long when it's greater than 440 milliseconds in men, or 460 milliseconds in women. Let's say that you measure someone's QT interval at a different rate though, say 90 beats per minute, and it ends up being 400 milliseconds. You might think that based on what we just said that'd be considered normal, but you can't really use this to compare to the values at 60 beats per minute, since the QT interval changes depending on the rate. As the rate increases, the QT interval decreases. So at 60 beats per minute, the abnormal cutoff might be 440 milliseconds, whereas at 90 beats per minute, it's likely something lower. So what we have to do is find the corrected QT interval, or QTC, at the different rates so that you can compare it to the QT interval at 60 beats per minute. Even though there are several formulas you can use, the Bizet's formula is probably the simplest, where the corrected QT interval equals the QT interval in milliseconds divided by the square root of the R to R interval in seconds divided by 1 second. As a bit of a side note, usually this formula is expressed without the divide by 1 second bit, but the astute observer will notice that the units won't work out if you don't divide by 1 second. Alright, so let's use our 90 beats per minute and 400 millisecond QT interval from before, and also assume that it's a male. If we plug in 400 for QT and 90 beats per minute, which is the same as 0.66 seconds per beat, we have a QT of 400 milliseconds divided by the square root of 0.66 seconds over 1 second, which is 400 milliseconds divided by 0.81, which remember is unitless. And so we get a corrected QT interval of 493 milliseconds. Now if we compare this to the value at 60 beats per minute, we can see that the corrected QT interval is actually greater than 440 milliseconds, which means that this measured QT interval of 400 milliseconds at 90 beats per minute is actually abnormally long. Finally, here are some factors that can affect the QT interval. First up, both hyper and hypocalcemia, meaning too much or too little calcium in the blood, respectively. Hypercalcemia typically shortens the QT interval, while hypocalcemia lengthens it. The QT interval can also be prolonged by medications, like amiodarone, which is an antiarrhythmic that affects cardiomyocyte ion channels, or caused by inherited long QT syndromes, where there are mutations in genes, including LQT1, LQT2, or LQT3. One of the most feared complications of having a prolonged QT interval is a type of ventricular tachycardia that can lead to sudden cardiac death, called torsade de pointes, where the ECG shows a twisting of the points. Alright, as a quick recap, an ECG waveform has a PR interval that's usually 120 to 200 milliseconds, a QRS complex that's less than 100 milliseconds, and a QT interval that's less than 440 milliseconds in men and 460 milliseconds in women. But it's important to remember that these are the rates at 60 beats per minute, and the Bazette formula can be used to find the corrected QT interval to compare to rates other than 60 beats per minute. An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few things to keep in mind, and one of them is figuring out the QRS transition. The chest leads, V1 through V6, view the heart through the horizontal plane, and each one has its own slightly different view. These views will have a mostly positive deflection if a depolarization wave is moving toward them, and a mostly negative deflection if the depolarization wave is moving away from them. The QRS transition zone refers to where the QRS complex switches from being mostly negative to mostly positive from the point of view of the chest leads. The QRS transition usually happens in lead V3 or V4, depending on things like chest lead placement and the exact anatomy of a person's heart. So the QRS transition tells us when the overall QRS vector is aligned in the direction of the chest leads. It's kind of like a way of understanding what's happening to the QRS axis on the horizontal plane. If something alters the heart's overall QRS vector, then the QRS transition zone might shift to the right, toward V1 and V2. An example is a myocardial infarction, which leads to the formation of scar tissue that can't depolarize. Generally speaking, the QRS transition zone will shift away from the region of scar tissue, since it no longer contributes to the overall QRS vector. So in order for it to shift right, the infarction would have to be on the left side of the heart. For example, a blockage in the left circumflex artery can cause infarction of the posterior wall of the left ventricle, and that would lead to a rightward rotation of the QRS transition zone, toward V1 and V2. Another example of a rightward shift is cardiac hypertrophy, because a thicker muscular wall contributes more to the overall QRS vector. So in this case, in order for it to be a shift to the right, it'd have to be a right ventricular hypertrophy. On the flip side, there can also be a shift to the left, toward V5 and V6. And this can have the same causes, except this time it'd be a myocardial infarction on the right side of the heart, or hypertrophy on the left side of the heart. Alright, as a quick recap, the QRS transition zone in the horizontal plane is where the QRS complex switches from being mostly positive in V5 and V6 to mostly negative in V1 and V2. So it normally happens in lead V3 or V4. The QRS transition zone rotates away from previous myocardial infarctions and toward hypertrophied tissue. An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind, and one of them includes figuring out the axis. The axis of an ECG is the average direction of electrical movement through the heart during a depolarization. More specifically, axis usually refers to the mean QRS vector, which is the size and direction of the depolarization wave as it moves through the ventricles. Normally, the QRS axis aims downward and to the left in relation to the body. So if we simplify this heart a bit, normally the sinoatrial or SA node sends an electrical signal that propagates out through the walls of the heart and contracts both upper chambers. And then that signal moves to the atrioventricular or AV node, with the signals delayed for a split second, and then goes down into the ventricles, or lower chambers, where it moves down into the bundle of His into the left and right bundle branches, and into each ventricle's Purkinje fibers, causing the ventricles to contract as well. So in a healthy heart, the upper chambers contract first, then shortly after the lower chambers contract. On an ECG, the atrial depolarization and contraction is seen as a P wave. The ventricular depolarization and contraction is seen as a QRS complex, and the ventricular repolarization, and therefore its relaxation, is seen as a T wave. The general principle to keep in mind is that the depolarization is caused by the movement of positive charge. So if that movement of positive charge is going toward the positive electrode, then it's captured as a positive deflection on an ECG. With that in mind, let's take a closer look at the mean or average QRS vector. After the depolarization wave arrives at the AV node, it travels down the interventricular septum and starts depolarizing the ventricles. The Purkinje fibers sit just below the endocardium, which is the innermost layer of the heart. After the endocardium is the myocardium, the cardiac muscle cells, and then finally there's the epicardium, which is the outer layer. So the Purkinje fibers initiate depolarization vectors that travel directly outward, starting in the endocardium, going through the myocardium, and ending in the epicardium. And because they transmit a depolarization wave so quickly, they all fire off pretty much in unison. Also, the more muscle tissue in the myocardial layer that a vector travels through, the larger the size of the vector. So like with hypertrophic cardiomyopathy, where the heart muscle gets thicker, you end up with bigger vectors. Although if the heart muscle's been damaged from something like a heart attack, then you get smaller vectors because the heart cells can't depolarize anymore. Another thing that can affect vectors is the position of the diaphragm, which is usually sort of sitting right up against the heart. In obese people, the diaphragm gets pushed upward, which rotates the heart further to the left. And in thin individuals, the diaphragm lowers, which rotates the heart a bit the other way. When everything's taken into consideration, all of the individual vectors are added up, and then there's one overall representative vector arrow, which starts from the AV node and points in one direction through the ventricles. Now, remember that vectors can be broken down into two perpendicular vector components. So if you look at the component that points at the positive lead electrode, that's what gets recorded on the ECG. And therefore, when you plot these vectors over the course of a ventricular depolarization, you end up with the QRS complex. So to figure out the direction of the axis in the frontal plane, we can start by looking at lead 1 and AVF. Lead 1 moves from right to left across the heart, so anything pointing to the left will be positive in lead 1. AVF, on the other hand, points downward, so any vector pointing downward will be positive in AVF. Looking at our overall vector from before, it's pointing both down and to the left, both positive, so it's in the bottom left quadrant between 0 and plus 90 degrees, and that's a normal axis. If it's positive or up on an ECG and 1 in AVF, you can imagine that's like seeing two thumbs up, meaning that everything's okay. If the vector's positive in lead 1 and negative in AVF, then it's in this quadrant, and it could also be normal if it's between 0 and negative 30 degrees. If it's between negative 30 and negative 90 degrees though, it could be considered left axis deviation. Left axis deviation can happen when the left ventricle hypertrophies, or when the right ventricle gets damaged and loses healthy tissue. If the opposite happens and the vector's negative in lead 1 and positive in AVF, then it's in this quadrant between plus 90 and plus 180 degrees, and we call that right axis deviation. That can happen when the right ventricle hypertrophies, or when the left ventricle is damaged and loses healthy tissue. Finally, if the vector's negative in both lead 1 and AVF, then that's a super rare case called extreme right axis deviation, which is between negative 90 and plus 180 degrees. This can sometimes happen when there's an ectopic focus that causes depolarization to start from the bottom of the ventricles and travel in the reverse direction. It's also a good idea in this case to double check that the leads are placed correctly. Now, you can figure out the QRS vector within about 30 degrees by looking at someone's ECGs, specifically the 6 leads 1, 2, 3, AVR, AVL, and AVF, corresponding to 0 degrees, plus 60 degrees, plus 120 degrees, minus 150 degrees, minus 30 degrees, and plus 90 degrees, respectively. Lead 1 here is clearly positive, which means that the axis is somewhere over here. And lead AVF is positive as well, putting the axis in the lower left quadrant between 0 and plus 90 degrees, which is a normal axis. To be a bit more precise, it looks like lead 3 is the closest to being isoelectric, which means it has equal positive and negative deflections. Since it's not pointing directly at or away from any vectors, it must actually run perpendicular to the QRS vector. So it must be 120 degrees minus 90 degrees from lead 3, which is at the plus 30 degree line. Notice that this happens to sit on the same line as AVR, but in the opposite direction. So we'd guess that this vector should look negative in AVR, and in fact it does. Now let's switch gears and talk about the chest leads, which essentially view the heart in a horizontal plane. Now, looking down at the heart, we have leads V1, V2, V3, V4, V5, and V6. Normally, the QRS complex is negative in leads V1 and V2. It's isoelectric in leads V3 and V4, which is called the transition zone, and positive in leads V5 and V6. Here, the horizontal axis of the heart lies along the isoelectric chest lead. If that transition zone shifts toward V1 or V2, then it suggests that the heart might be rotated to the person's right, which can happen if the right ventricle is hypertrophied. On the flip side, if leads V5 or V6 look isoelectric instead of positive, it suggests that the heart might be rotated to the person's left, which can happen if the left ventricle is hypertrophied. Alright, as a quick recap, a normal heart axis is between negative 30 and plus 90 degrees. Right ventricular hypertrophy can cause the axis to be between plus 90 and plus 180 degrees, and can sometimes cause the transition zone to shift towards the V1 and V2 chest leads. Left ventricular hypertrophy can cause the axis to be between negative 30 and negative 90 degrees, and can sometimes cause the transition zone to shift towards the V5 and V6 chest leads. An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind. One of them includes figuring out the rate and the rhythm. Now, there are a couple ways of figuring out the heart rate on an ECG. The first one is called the box method because you count the number of boxes between heartbeats. Each small box represents 0.04 seconds, and each big box is 5 small boxes. So each big box is 0.2 seconds. So to calculate the heart rate, you can count the number of small boxes between R waves, since R waves are tall and pointy and easy to see on lead 2 of an ECG strip. You can find an R wave that has a peak that falls at the beginning of a box, and then count up how many boxes until the same point on the next R wave. So let's say that there are 4 big boxes and 1.5 small boxes between 2 R waves. Since you have 4 big boxes, that means 4 times 5 small boxes, plus that extra 1.5 small box, totals to 21.5 small boxes. And that means that there are 0.04 seconds times 21.5, or 0.86 seconds between heartbeats. So the units here are seconds per heartbeat. Now, to get something a little more meaningful, we can take the inverse of that, which is 1 over 0.86 beats per second, or 1.16 beats per second. Now, since there are 60 seconds in a minute, we can multiply this by 60 and end up with 70 beats per minute, which is the heart rate. Now, if the distance between 2 R waves is exactly 1 box, then the heart rate would be 300 beats per minute, which is really fast. If R waves are 2 big boxes apart, or 0.4 seconds, then the heart rate is 150 beats per minute. 3 big boxes apart is 100 beats per minute, 4 big boxes is 75 beats per minute, 5 big boxes is 60 beats per minute, and finally 6 big boxes apart is 50 beats per minute. Remembering these numbers makes it easier to make a rough estimate of the rate. For example, if there are between 3 and 4 big boxes between R waves, then we know that the heart rate must be between 75 and 100 beats per minute. Another method to figure out the heart rate is to count the number of beats in 10 seconds, which is the standard length of time in the rhythm strip portion of a 12-lead ECG. So in this case, we can count 15. Since this is a 10-second interval, all you have to do is multiply this by 6 to get the heart rate, which would be 90 beats per minute. The reason this little trick works is because you have 15 beats per 10 seconds. And again, to convert to per minute, you multiply by 60 seconds in a minute. Looking at this, we see that 60 divided by 10 equals 6 per minute. So 6 times 15 is 90 beats per minute. If the heart rate is too fast or too slow, it could be because something other than the SA node is pacing the heart. For example, there could be atrial flutter, which is when an ectopic focus in the atria, like an irritated atrial cell, starts to spontaneously fire between 250 and 350 depolarizations per minute, with only 1 out of every few atrial depolarizations passing through to the ventricles. To calculate the atrial rate, you can use the same methods as before, except you look at P waves instead of R waves. If one P wave starts on a heavy line, and the next P wave starts in the next heavy line, or 0.2 seconds later, then again you've got one beat for every 0.2 seconds. And multiplying by 60 seconds in a minute, you get 300 beats per minute. You could also remember that nifty trick where one big box is equal to 300 beats per minute. Another situation is atrial fibrillation, which is when there are multiple ectopic foci in the atria that start firing all at once. The atrial rate here can increase to 350 to 450 beats per minute. In this situation, only the occasional firing of an ectopic focus that happens to be near the AV node is able to make it through and down to the ventricles. The ectopic foci fire too quickly for the atria to be fully depolarized by any one of them. So with atrial fibrillation, there aren't any P waves on an ECG, but rather small waves that reflect waves of atrial depolarization that couldn't make it through the AV node. Of note, the 350 to 450 beats per minute reflects all the times the atrial foci fire in a minute, and not the rate of the ventricular depolarization. So with atrial fibrillation, the ventricular rate is much lower than the atrial rate, but still over 120 beats per minute, and highly irregular, meaning that the distance between the QRS complexes is not equal. Normally on an ECG, one waveform with its P wave, QRS complex, and T wave looks just like the next one, almost like they were just copied and pasted one right after another. And that's how a regular rhythm looks. An irregular rhythm, on the other hand, is when there's any change in the timing of the QRS complexes. To help identify ECG abnormalities, you can look to see if every part of the waveform looks exactly the same, which would include the P wave, the QRS complex, and the T wave. If not, it could mean that there's an ectopic beat, meaning that it might have originated from an abnormal spot in the atria or ventricles. For example, this first P wave is deflected upwards, and the second is deflected downwards, which would indicate that it's an ectopic beat. Alternatively, an odd-looking waveform might have originated from the normal spot, which is the SA node, but then gotten thrown off course, which is what happens when there's a block someplace. In this example, there's a bundle branch block, which is where the signal can't go down one or both of the bundle branches, and this usually results in these wide QRS complexes. Next, you could check for changes in the sequence of the waves, most often involving the two depolarization waves, the P wave and the QRS complex. You can look to make sure that there's a P wave before every QRS complex, as well as a QRS complex after every P wave. For example, if there's a premature ventricular contraction like this, then there might be a QRS complex without a preceding P wave. On the flip side, if there's a third-degree AV block, the atria and ventricles have completely separate electrical activity, kind of like two people dancing to different songs at the same time. So in this case, there can be P waves that are not followed by QRS complexes, and the ventricular rate is usually low, around 40 beats per minute. Also, don't forget the most common irregular rhythm, which is atrial fibrillation, in which case there are no P waves, and irregular QRS complexes. Alright, as a quick recap, one quick way to estimate the heart rate on an ECG is to remember that one big box is 300 beats per minute, two big boxes is 150 beats per minute, three big boxes is 100 beats per minute, four big boxes is 75 beats per minute, five big boxes is 60 beats per minute, and six big boxes is 50 beats per minute. To help identify an irregular rhythm, you can look at the waveforms and see if there is any variation in the timing of the QRS complexes. An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg, So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection. Like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To read an ECG, there are a few key elements to keep in mind. And one of them includes figuring out if part of the heart is suffering from ischemia or has had an infarction. The term ischemia means that blood flow to a tissue has decreased, which results in hypoxia, or insufficient oxygen to that tissue. Whereas infarction goes one step further and means that blood flow has been completely cut off, and this results in necrosis, or cellular death. That typically happens if blood flow has been cut off for about 20 minutes. In the heart, ischemia and infarction can be transmural, affecting the entire thickness of the myocardium. But it can also be subendocardial, affecting just the innermost part of the myocardium, the part just beneath the endocardium. Out of all four chambers of the heart, the ECG is most sensitive to transmural or subendocardial ischemia or infarction in the left ventricle, because that's the chamber with the thickest walls and therefore has the most cardiac tissue. Alright, so let's start with subendocardial ischemia, which might happen when there's an incomplete blockage, let's say about 70%, in the coronary artery. In that situation, at rest, there's usually enough blood flowing to meet the demand of the myocardium. But during exercise, there's not enough to meet the myocardium's increased demand. In that situation, the subendocardial tissue gets ischemic, because it's the last bit of tissue to get blood from the tiny branches of the coronary arteries as they make their way through the ventricular wall from outside to inside. This condition is called stable angina, because there's ischemia which causes chest pain with exercise, and then it disappears with rest. And there's also unstable angina, which can happen with incomplete blockage of a coronary artery, but in this case, chest pain appears at rest. When there's subendocardial ischemia in a region, it causes ST depressions in the corresponding lead on the ECG. An ST depression is when the J point, which is where the QRS complex meets the ST segment, goes down by at least 0.5 millimeters, or 1/2 of a small box. The ST depression can be upward sloping, downward sloping, or horizontal. In subendocardial ischemia, ST depressions are usually widespread, often affecting leads 1, 2, and V4 through V6. With such widespread involvement, it's tough to determine which coronary artery caused the ST depression. As a little side note, if the ST segment is depressed and curved, it might actually be due to digitalis effect, which is when the patient takes the medication digoxin, rather than being due to subendocardial ischemia. On the other hand, subendocardial infarction happens if the coronary artery remains blocked for around 20 minutes, and the subendocardial cells begin to die, resulting in necrosis. And with necrosis, the subendocardial cells leak cardiac enzymes, like troponins and CKMB, into the blood. With a subendocardial infarction, there is no ST elevation on the ECG, so this is called a non-ST elevation myocardial infarction, or an NSTEMI for short. Instead, the ECG can show ST depression and T-wave inversion. On ECG, both unstable angina and NSTEMIs might show ST depression as well as T-wave inversions. The difference is that with NSTEMIs, cardiac enzyme levels in the blood are elevated, whereas with unstable angina, the damage resolves in a short time window, so there's no cardiomyocyte death, and therefore no elevated cardiac enzymes. With an NSTEMI, the ST depression looks similar to the one in subendocardial ischemia, and the T-wave inversions are usually symmetric and at least 1 millimeter deep, or one little box, and are most noticeable in the chest leads, but can also appear in the limb leads. These also have to happen in at least 2 contiguous leads, meaning adjacent leads. For example, lead V2 and V3 are contiguous, but leads V3 and V5 are not contiguous. There can also be a dominant R wave, meaning that the R wave has a higher amplitude than the S wave. Now, it actually turns out that a little bit of T-wave inversion can be normal, especially in leads 3, AVR, and V1. But any sign of T-wave inversion in leads V2 through V6 is considered abnormal. All right, so next there's transmural ischemia. And this can happen when a coronary artery is narrowed from an atherosclerotic plaque buildup over time. Now, there are two parts to this plaque: a hard fibrous cap and a soft cheese-like interior. As the blood flows past the plaque, the fibrous cap can sometimes rip, and that cheesy interior is exposed and considered thrombogenic, meaning that blood clots form on it really quickly. And that can quickly plug up blood flow.
Transmural ischemia can happen secondary to vasospastic angina, also called Prinzmetal angina, which is when a coronary blood vessel spasms and narrows, cutting off blood flow to that cardiac region. Vasospastic angina happens independent of traditional risk factors, like atherosclerosis, and can be triggered by tobacco, alcohol, or cocaine use.
Finally, we have transmural infarction, which happens when a coronary artery becomes completely blocked for greater than about 20 minutes, and this causes transmural necrosis. Within minutes, a transmural infarction leads to ECG changes. The most common would be a T-wave inversion, but there might also be hyperacute T waves, which are large asymmetric T waves that appear in at least two contiguous leads. The classic sign of transmural infarction is ST elevation, and when that happens, it's called an ST elevation myocardial infarction, or STEMI. On ECG, the ST elevation at the J point must be over 1 millimeter in any two contiguous leads except V2 or V3, where it has to be over 2 millimeters.
On an ECG, both a STEMI and vasospastic angina can cause ST elevations, but with vasospastic angina, the elevation is transient. Another key difference is that with a STEMI, the ischemia is so severe that damaged heart cells die, resulting in myocardial necrosis, and leak out certain enzymes like troponin and CKMB.
ST elevation, though, can also be caused by other conditions, like left ventricular hypertrophy and pericarditis. As an example, a 20-year-old physically fit person with a viral illness that gradually develops chest pain and is found to have ST elevation on ECG is actually more likely to have pericarditis than an ST elevation myocardial infarction.
Besides ST elevation and T-wave inversions, a transmural infarction can also cause pathologic Q waves to appear on the ECG.
Normally, depolarization in the ventricle spreads from the endocardium to the epicardium, and most of that ends up pointing toward the positive electrode, which means a positive deflection. With infarcted tissue, though, it doesn't conduct electricity, which means that the electrode essentially sees through the infarcted tissue, sort of like as if it was just a hole. And it sees through the hole to the other ventricular wall. And since those are mostly moving away from the positive electrode, you end up with this big, negative pathologic Q wave. So pathologic Q waves are those that are longer than 0.04 seconds, or one small box, and over 2 millimeters, or two small boxes deep. Now, the location of the transmural infarction can be identified based on the lead that has pathologic Q waves. Septal wall infarctions show changes in leads V1 and V2, whereas anterior wall infarctions show changes in leads V3 and V4. Anterolateral wall infarctions show up in leads V3 through V6, as well as 1 in AVL. Small subendocardial infarctions don't actually cause pathologic Q waves, because some of the affected wall still conducts electricity. Also, the AVR lead is oriented in a way that normally produces Q waves, so it's actually not a reliable lead to look for pathologic Q waves. Finally, pathologic Q waves can also result from things other than transmural infarction, like a left bundle branch block and Wolff-Parkinson-White syndrome. After a transmural myocardial infarction, the ECG gradually starts to look more normal. During the first 2 days, there might be T-wave inversion, ST segment elevation, and pathologic Q waves. But around day 3, the ST segment's often back at baseline. After a few weeks or months, the T-wave inversion might start to improve as well. But pathologic Q waves can linger for a lot longer. And this is why it's always important to compare ECGs to previous ones to look for new changes. Alright, as a quick recap.
Subendocardial ischemia can reflect stable or unstable angina. Subendocardial infarction causes an NSTEMI. Stable angina, unstable angina, and NSTEMIs are associated with ST depressions and T-wave inversions on ECG. But the difference is that with NSTEMIs, there are elevated cardiac enzymes like CKMB and troponins in the blood. Transmural ischemia can reflect vasospastic angina, whereas transmural infarction leads to a STEMI, and this causes ST elevation on an ECG. The key difference is that with vasospastic angina, the ST elevation is transient, and with a STEMI, there are elevated cardiac enzymes in the blood. Additionally, with a STEMI, the ECG can show T-wave inversions and hyperacute T waves, as well as pathologic Q waves.
An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. Now, there are lots of things to look for when reading an ECG, and one of them includes figuring out if part of the heart has undergone hypertrophy or enlargement. Hypertrophy means that the heart's muscular walls increased in thickness, while dilation refers to an increase in the volume of a chamber. The term enlargement is generally used when both hypertrophy and dilation happen together, and this is what typically happens in the atria. In contrast, the ventricles often undergo hypertrophy without dilation. An ECG can show evidence of hypertrophy and enlargement in all the heart's 4 chambers, so let's go through them one by one. Normally, atrial depolarization produces a pretty normal-looking, symmetric P wave. In right atrial enlargement, all that extra right atrial muscle tissue results in a large P wave in leads V1 and V2, often over 1.5 millimeters, as well as in the inferior leads 2, 3, and AVF, often over 2.5 millimeters. One reason why right atrial enlargement develops is that there can be a stenotic or narrowed tricuspid valve, and that makes it difficult for the right atrium to eject blood into the right ventricle, and in response the right atrium enlarges. In left atrial enlargement, the left atrium has extra muscle tissue, and that results in a P wave with 2 peaks in lead 2, with the entire thing stretching out over 110 milliseconds, with a gap of over 40 milliseconds separating the 2 peaks.
With left atrial enlargement, the P wave in lead V1 is biphasic, meaning that it looks like a hill with a valley alongside it. However, that can also be seen in healthy individuals. The key difference between a normal and pathological biphasic P wave in V1 is that with left atrial enlargement, the negative portion is usually more than 1 millimeter deep and lasts for more than 40 milliseconds.
Left atrial enlargement also develops from a stenotic valve, but this time it's the mitral valve on the left side, which causes the left atrium to get bigger. Normally, the QRS complex is mostly negative in lead V1, because the large left ventricle, which carries the greatest amount of muscle tissue, is oriented down and away from this electrode. In right ventricular hypertrophy, the thicker right ventricle helps to counterbalance the left ventricle, and so it makes lead V1 more positive. More specifically, it makes the R wave bigger, which is the upward deflection of the QRS complex. In fact, a dominant R wave in V1 is a classic sign of right ventricular hypertrophy, and it's defined as one that's over 7 millimeters tall, or 7 little boxes, and is larger than the S wave, making the R to S ratio greater than 1. In V5 and V6, another classic sign of right ventricular hypertrophy is a dominant S wave, meaning that it's over 7 millimeters deep, again 7 little boxes, and bigger than the R wave, making the R to S ratio less than 1. Typically, there's also right axis deviation in right ventricular hypertrophy, resulting in an axis of plus 110 degrees or more. In right ventricular hypertrophy, the QRS complex is less than 120 milliseconds, meaning that it's not longer than normal. This is important because it means that the changes can't be the result of something like a right bundle branch block, which would cause a longer than normal QRS complex. Right ventricular hypertrophy can develop for a number of reasons, a common one being pulmonary hypertension, which makes sense because the right ventricle has to build up muscle to push blood against higher pressure into the lungs. In left ventricular hypertrophy, the pattern is almost the opposite of what happens in right ventricular hypertrophy. Lead V1 has even more positive charge traveling away from it than usual, making the S wave really deep. Meanwhile, lead V5 and V6 are located on the side of the left ventricle, and therefore have an enormous R wave. The most commonly used voltage criteria to identify left ventricular hypertrophy is that adding up the S wave in V1 and the tallest R wave in V5 or V6 has to be over 35 millimeters, or 35 little boxes. Additional criteria include things like having an R wave that goes on for longer than usual, typically over 50 milliseconds, as well as ST segment elevation in V1 and ST segment depression and T wave inversion in V5 and V6. And these are all signs that the left ventricle is straining during muscle contraction. Left ventricular hypertrophy commonly develops due to systemic hypertension, or elevated systemic blood pressure, since the left ventricle needs more muscle so that it can eject blood against higher pressures. Alright, as a quick recap.
Right atrial enlargement shows a big P wave in lead 2 and V1, whereas left atrial enlargement has a biphasic P wave in lead V1 with a negative component greater than 1 millimeter deep and lasting more than 40 milliseconds, as well as a double humped P wave in lead 2.
Right ventricular hypertrophy shows a big R wave in V1 and a big S wave in V5 and V6, whereas left ventricular hypertrophy shows the opposite, a huge S wave in V1 and a huge R wave in V5 and V6, adding up to over 35 millimeters,